very good evening and a warm welcome to one and all present in this ICA webinar. Team Planet is very proud to be a part of this journey. So now without further delay, I would like to hand over the session to Dr. Radhakrishnan sir, who is President of ICA. Sir, over to you.
Good evening, all my colleagues and friends, and welcome to the webinar of Indian College of Anesthesiologists. For the day, the topic is one of the loveliest areas in the clinical medicine. When we join as a medical student, in the first month of your studies, you're going to learn about neuromuscular transmission. And that's going to remain till the very end of your life. And the second part of the neuromuscular transmission, we're going to learn more about the muscle relaxants, and which for anesthesiologists till the last day of practice going to remain. That means one of the most romantic area in clinical medicine is neuromuscular monitoring, muscle relaxant, especially the discovery of muscle relaxants and the Chris Merrill expedition of South America. And my friends, when you get time, look into the library and the old recordings, as well as a write-up on the expedition and how they reached the muscle relaxants and how muscle relaxant change the phase of anesthesia conduction. And today we're going to discuss the first part, is the neuromuscular monitoring. We're going to discuss the physiology, pharmacology, monitoring, and some neuromuscular disorders which are of importance to us and which gives us some implications in our conduct of anesthesia. And today, the speakers are Rakhee Goyal, Lakshmi, Poornachand, and Abhijit. And today's main moderator is Dr. Elsa Varghese. Well, I'm sure Elsa is known to you all well. Elsa Varghese, well, was at the Manipal University of, and well, we know each other over the last 5 decades. And I'm so happy to see Elsa on the platform. And I welcome Dr. Elsa. And Elsa is the main moderator. Elsa is going to be assisted by Basanth, Rayani, and Vaibhavari Naik. Basanth, I'm thankful to you to size me this topic and to bring over. And Vaibhavari, you are too good to give all the touchings to the particular topic and bring it over. And without wasting my time, I request Elsa to start off this particular webinar, which is of use to everybody every day. And thank you for selecting this particular topic. Go ahead.
Thank you, Dr. Radhakrishnan. It's indeed a pleasure being. Can you hear me?
Yes, I can hear you.
Yeah. Yes, well, it's indeed a pleasure being back with you on the same platform. And as you say, it's after a big break. And thank you very much, the Indian College of Anesthesiologists and Clarinet for inviting me to be the moderator for today. And as Dr. Radhakrishnan said, this maybe is it just our generation, Dr. Radhakrishnan, who get so excited when we hear about neuromuscular monitoring and the neuromuscular junction? Because believe me, when we were training, it was then that they were discovering the actual details of the molecules of the acetylcholine receptor and the proteins and how many proteins there were and how the passage of electrons took place in and out. And for me, that was so fascinating as a resident in anesthesiology that I wanted to actually fly out and meet this couple, ward and ward, who had dedicated their life to this. So I truly am so happy that this topic has been allotted today. And it's not theoretical, because as Dr. Radhakrishnan said, we are using these drugs every day, and we need to know in a fascinating manner in which they work, how they work, why do things happen, and how does it affect our clinical practice. So today it gives me great pleasure in introducing Dr. Rakhee Goyal. Dr. Rakhee Goyal is a senior anesthesiologist and head of department of Rainbow Children's Hospital.
Hello.
At the moment, she is a dedicated
Yes.
pediatric and probably an obstetric anesthesiologist. And she is, as you notice, she has a colonel in front of her name, and she has served in the army and in very remote areas like Leh, and served, done amazing job in terrible, very, very difficult conditions. And now she's dedicated her life to taking care of our wonderful children. And she has great enthusiasm, and I'm sure you will enjoy listening to her lecture today on neuromuscular physiology. Over to you, Dr. Rakhee Goyal.
Thank you, ma'am. Thank you for your kind words. Thank you, ICA, and good evening, friends. Can I have the video on? Yeah, thank you. So today I'm going to talk about neuromuscular physiology. And my objectives of the talk would be to tell you in a very simple manner, what is the structure, what are the components of this neuromuscular junction, what are the electrical and the mechanical events going on here, the physiology of transmission of an axon potential, and in very brief, I would mention how the neuromuscular blocking drugs act. So what is neuromuscular junction? Is it an anatomical synapse? Is it chemical? Or is it electrical? Is it very complex? Are we perplexed with a diagram like this? It's too many words and too many colors here. When I was training, I would confess today, I was intimidated by this kind of a diagram, and I wouldn't understand what's going on. But over the years, you realize that if you simplify each step, it is very interesting, and I'm sure you're going to love this. So to begin with, a neuromuscular junction facilitates a chemical transmission of the electrical impulse that is coming from the brain and coming here at the nerve ending. This is the nerve ending. Here is the muscle fiber. This is the muscle fiber, which we also call as the motor end plate. And this here in between the nerve ending and the muscle fiber is the synapse. So the transmission is from the nerve ending through the synapse into the muscle fiber, resulting in muscle contraction. And this one unit is called a motor neuron unit. The motor nerve ending, the synaptic cleft, and the motor end plate. Now, there are three types of muscles where these NMJs are: the skeletal muscle, the smooth muscles, and the cardiac muscles. So the most elaborate discussion is on the NMJ of skeletal muscle. Here, the nerve impulse starts from the ventral horn of the spinal cord. The axon of the efferent motor neuron comes. When it reaches a skeletal muscle, it breaks into these nerve endings. And these nerve endings, they embed into the plasma membrane of the skeletal muscle, which is the motor end plate. Now, as they reach this muscle fiber, what happens is this myelin sheath, which was there on the axon, it gets lost. Here, as you see, there is no myelin sheath. And this expands in this shape. It's called the terminal button. Now, there are 100 to 200 branching of these nerve endings when it reaches the muscle. This is covered by the Schwann cells. And there are many voltage-gated calcium channels like this, here in this nerve ending. Also are present mitochondria, endoplasmic reticulum, and synaptic vesicles like these in the cytoplasm. Now, coming to these synaptic vesicles, now these are the ones that store the acetylcholine, the main neurotransmitter of this entire transmission. There are about 5,000 to 10,000 molecules of acetylcholine in each of these synaptic vesicles. Now, in each vesicle, it's called quanta, the amount of acetylcholine. So we say 100 to 200 quanta of acetylcholine when it's released, which causes the transmission. But these are located at the active zones. Now, this near the presynaptic membrane are the active zones, which are the areas of membrane thickening on the nerve. Now, these are the ones that contain many types of proteins. They're commonly called snare proteins or snap proteins. And there are rows of voltage-gated calcium channels. Now, what happens is when the axon, the nerve impulse travels from the spinal cord to the nerve endings, these calcium channels open up. And the calcium comes from outside to inside the nerve terminal. It docks onto these proteins and helps in the vesicles in the active zones to cause a release of acetylcholine through exocytosis. Now, they are released into the synaptic cleft here. Between the presynaptic membrane and the postsynaptic membrane, as we discussed, there is a synaptic cleft. And this is where these synaptic vesicles, they release acetylcholine by exocytosis. Now, this cleft is about 30 to 50 nanometers in size. And beyond, and it contains the enzyme called acetylcholinesterase. Now, this is going to help in further breakdown of the acetylcholine when it comes back. Now, so we've seen the nerve ending, the synaptic cleft, that's a synapse. And then we have the motor end plate, the muscular part. Here, as I'm showing on the pointer, this hole is the motor end plate. This is the postsynaptic part of the neuromuscular junction. And the thickened portion of the muscle plasma membrane is called sarcolemma. This is thrown into folds. It's called junctional folds. They're crests and clefts. Now, here on the crest are the nicotine acetylcholine receptors. They're concentrated at the top of the crest. Now, when acetylcholine attaches to these receptors, the ligand-gated ion channels open up. These are the sodium channels. And the sodium is influxed from extracellular fluid into the muscle membrane. At the same time, some amount of potassium is going out, but the amount of sodium influx is way more than the potassium that's going out. Now, this creates an end plate potential and generation and transmission of the axon potential to the muscle membrane. Now, this is a typical structure of a nicotinic acetylcholine receptor. This one on the left side is a typical adult receptor where you have these 5 subunits, but the acetylcholine attaches itself to the alpha subunit here and here. And when it attaches, the center is the roseate shape where the center opens up and here the sodium influx happens. Now, besides these standard adult junctional receptors, we could also have fetal or extrajunctional receptors. Now, in the neonatal period, the fetal receptors are present. By and large, they are same except for this subunit. This is different than the adult subunit. We'll come to it. Now, what is happening at the motor end plate potential? What is the electrical part that's going? Now, as I said, a single quanta will release acetylcholine from a vesicle. this creates a miniature end plate potential. But when, now this is not good enough for a muscle contraction, but when 100 to 200 or more than that quanta of acetylcholine are released, an end plate potential is created. It depolarizes to a threshold level. When it reaches that threshold level, the sodium channels open further and the action potential is produced for about 5 to 15 milliseconds. Now, the baseline was minus 90 millivolts. Now, when the sodium comes in, it becomes more positive, which is minus 45 millivolts. And there is further sodium influx to take it to 50 to 100. Now, that's when the whole action potential effectively transmits, resulting in muscle contraction. Now, what else is happening simultaneously is the remaining acetylcholine, it gets hydrolyzed by this enzyme that we talked about, which was present in the synaptic cleft. It goes back to becoming choline and acetate. And half of the choline gets returned by an active process, sodium choline transport system, to be reused by the nerve ending for further production of acetylcholine. Now, besides that, there is a positive feedback control of the release of acetylcholine in the presynaptic part, which, by the way, also has some presynaptic acetylcholine receptors. I'll show that in the figure. So there are pre and extrajunctional acetyl receptors besides the nicotine acetyl receptors. I'll show it in the figure. It's much easier. I'll show it in a while. So these get active. Normally, these are present in fetal receptors and in very small numbers in adults. But in cases of, say, denervation injuries or burns, they increase in numbers, and mainly in the postsynaptic membrane of the motor end plate. Now, why are we talking about them? We are talking because in these situations, as we know, there is a heightened sensitivity to our depolarizing muscle relaxants like succinylcholine. So as you have heard, in burns, we do not give, after 24 hours, we do not prefer to give succinylcholine because these junctional receptors are increased in numbers after this. At the same time, they have reduced sensitivity to our non-depolarizing muscle relaxants. Now we've talked about this part. This is the motor end plate. When the sodium channels opened, it created a transmission of the action potential. What happened here was this T-tubule in the muscle. The potential travels through the T-tubule and triggers calcium release from the sarcoplasmic reticulum of the muscle fibers. Now, calcium coming out from here, it binds to the troponin, which exposes the myosin binding sites. Now, this causes a cross-bridge cycle and the muscle fiber contracts, after which the tropomyosin blocks the myosin binding sites and causes a release of calcium. Now, this calcium is thrown back into the sarcoplasmic reticulum by an active process. So it's a circle which causes the muscles to contract because of the action potential. Now, this we talked about in the skeletal muscle. When we talk about the smooth muscle, they're slightly different than the skeletal muscles. They have autonomic nerve fibers. They branch diffusely. And importantly, besides acetylcholine, they have other neurotransmitters such as norepinephrine. The smooth muscles have many layers of muscles, and this action potential is traveling from outer to inner layers. Now, the clinical application comes here. In smooth muscles of the intestines, where the activity, the muscle activity is low, what happens is there's just one neuron which controls a large number of muscle fibers. Vis-a-vis eye muscles, the iris muscles, where the activity is fast, and the autonomic nerve branches less extensively and controls very few muscle fibers, because each muscle fibers has to act very fast. So that's the difference between different types of smooth muscles and how they are innervated. Coming to the cardiac muscles, they have multiple gap junctions because they have to rapidly contract the muscles. Each fiber is innervated by postganglionic, parasympathetic, and sympathetic nerve endings. And the nerve fibers, they end on the nodes as well, the SA node, the AV node, and the bundle of His as well to form the neuromuscular junctions. The ventricular muscle is also innervated by the sympathetic fibers. Now, if we quickly see how our neuromuscular blocking agents act, when we see the depolarizing agents like succinylcholine, they act like agonists at these nicotinic acetylcholine receptors on the motor end plate. And this is not hydrolyzed by the acetylcholinesterase enzyme. So there is a sustained effect. So this is the phase 1 block that we see. This release of acetylcholine is by repetitive firing, and it continues till the time the succinylcholine diffuses away and gets metabolized by another enzyme, which is plasma cholinesterase, also present in the synaptic cleft. Now, we could have a desensitization block or a phase 2 block in different scenarios. Coming to the non-depolarizing agents, unlike the depolarizing agents, they are antagonists at the level of acetylcholine receptors. However, they do not produce any conformational change in the receptor. They just bind to one or two subunits and prevent the access of acetylcholine by competitive manner. Now, what we should understand clinically is if the concentration of acetylcholine is increased, it has a higher chance of occupying the receptor sites than these non-depolarizing agents. So we do have a wide margin of safety when we use these muscle relaxants. So to summarize, I would say that when the action potential travels in a nerve ending, which has lost its myelin sheath when it's reached the muscle, there is opening of calcium channels that are voltage-gated, and these attach to certain proteins, causing the synaptic vessels to release the acetylcholine by exostosis into the synapse or the synaptic cleft. When this happens, in the motor end plate, which is thrown into junctional plates, there are sodium channels which are ligand gated, and they get opened up. There is influx of sodium into the muscle fiber, and this causes the release of calcium from the subplasmic reticulum, which causes the muscles to contract. And this acetylcholine, the remaining, gets degraded or hydrolyzed by acetylcholinesterase enzymes and goes back, some of it goes back for the production of acetylcholine. So step by step, it's a simple process. There are just 3 parts, and they're just one calcium channel and one sodium channel and acetylcholine that flows from the nerve to the muscle. So a complicated diagram like earlier becomes simple when we just go step by step into it. That's all from my side, and thank you for your patient listening.
Well, thank you so much, Dr. Rakhee. That was really so comprehensive and, as I say, exciting to tell us both the chemical and the electrical systems of neuromuscular transmission. And this is such an important basis that we all need to know before we can go on to the drugs that act on these receptors, and then how we can interpret about neuromuscular blockade, how much of it which will follow in the subsequent lectures. It's with great pleasure that I would like to invite Dr. Lakshmi Narasimhulu Poornachand. He is a very experienced anesthesiologist who did his initial undergraduate training in Andhra Pradesh, and he subsequently did his anesthesiology residency at in New York at the Methodist Hospital in Brooklyn, and after that he did a couple of fellowships, and he has great interest in neuroanesthesia and regional anesthesia. So he's really best person to have. He is currently an associate professor and director of neuroanesthesia at the University of Missouri Medical Center in Jackson, Mississippi. So over to you, Dr. Lakshmi.
Thank you, Dr. Elsa Varghese. My name is Lakshmi Poornachand. Thank you for the ICA and also the moderator for giving the opportunity. Today, I'm going to talk about the neuromuscular pharmacology. So no conflicts of interest. And this topic is divided into introduction, classification of muscle relaxants, depolarizing agents, non-depolarizing agents, reversal agents, and the conclusion.
Could we have your camera video on, please, Dr. Lakshmi?
I do. Thank you. So the slide showing is anesthesia is a balancing act. Thank you for Dr. Rakhee Goyal going through the neuromuscular physiology. As anesthesiologists, we need to know the anatomy, physiology, and based on the patient pathology, we can able to use our knowledge of pharmacologists to give the best possible patient care. Even though most of the patients and the outside people see the surgeon as a tip because he's on the top of the pyramid, but we form the base of the care for the patient so that we can able to provide best possible care, patient outcome. So the ideal muscle relaxant is the holy grail of general anesthesia. The muscle relaxant should have the quicker onset, the predictable offset, and you can able to use it in all the patients with the systematic diseases with the no or minimal side effects. The clinical uses of the neuromuscular blocker divided into provide the skeletal muscle relaxation to facilitate tracheal intubation, improve the surgical working conditions during the general anesthesia, to ventilate the patient in non-physiological ventilatory modes like the prone position ventilation and also the high frequency jet ventilation. But as anesthesiologists, we need to understand the muscle relaxant does not produce any sedation, amnesia, analgesia, or autonomic control. So that is one of the reasons the general anesthesia is a part of sedation or hypnosis, analgesia, amnesia, and the muscle relaxation. With all those four factors, you are able to provide the absence of the stress response. The classification of neuromuscular blocker are divided into based on the mechanism of action. They divided into depolarizing agents. The only muscle relaxant we use as the succinylcholine. The other ones are the non-depolarizing agents. Based on the duration of action of non-depolarizing agents, we divided into short-acting agents, intermediate-acting agents, and the long-acting agents. We will go over each medications in the future slides. The mechanism of action of the neuromuscular blockade, the depolarizing agents are long, thin, and flexible molecules. These agents bind to the alpha subunits of the acetylcholine receptors, mimicking the action of acetylcholine and cause depolarization. These subunits remain bound and further contraction prevented until the succinylcholine is metabolized. The other way, the non-depolarizing agents are heavy, bulky, rigid molecules, bind a single site on acetylcholine receptor and prevent further binding of acetylcholine to the receptor. So these are act as a competitive antagonist. The pharmacodynamics is nothing but what is the drug does to the body. The neuromuscular blocking drugs interrupt transmission of nerve impulses at the neuromuscular junction. There are few important words we need to understand, like the ED95 and the efficacy and potency. The ED95, also known as the effective dose 95, is the equal potency of the neuromuscular blocking drugs needed to produce 95% suppression of the single twitch response. The ED95 represents the potency of the neuromuscular blocker drug in the presence of nitrous oxide, barbiturate, and opioid anesthesia. On the other way, the potency is the amount of drug need to produce the similar effect. The onset of the neuromuscular blockade after the administration of non-depolarizing neuromuscular blocking drugs is more rapid but less intense at the laryngeal muscles than the peripheral muscles like the adductor pollicis. Because the muscles of the glottis, the thyroarytenoid contains the fast contraction fibers with acetylcholine receptors density is very high, whereas the adductor pollicis contains the slow fibers. The orbicularis oculi referred to the adductor pollicis as an indicator for the laryngeal muscle blockade at the beginning, but towards the end of the case or during the reversal, the adductor pollicis is the preferable indicator. This is the sequence of onset of the neuromuscular blockade. The neuromuscular blocking drugs act on the small, rapidly moving muscles like the eyes at the beginning, then next to the affect the neck muscles, then the trunk and abdominal muscles, and the last one is the diaphragm. In the recovery, the reverse order will follow. The pharmacokinetics are nothing but what is the body does to the drugs. That is kind of metabolism of the drugs. The neuromuscular blocking drugs are the quaternary ammonium compounds. These are highly ionized water-soluble compounds at physiological pH and possesses very limited or no lipid solubility. Because of the less lipid, no or less lipid solubility and higher hydrophilicity of these medications, the volume of distribution is limited to the extracellular fluid. The plasma clearance, the volume of distribution, elimination T-off influenced by the patient age, the medications along with the neuromuscular blocking agents we use like the volatile anesthetics, and the presence of systematic disease. So what is your rationale of choice for the muscle relaxation? It depends on what is the onset you needed for the muscle relaxation, what is the duration of action you needed for the muscle relaxation, the pharmacodynamic profile of the medication and the pharmacokinetic profile of the medication, and do you need to have the reversal at the end of the case. Coming to the depolarizing neuromuscular blocking drugs, currently we have only one medications in the depolarizing neuromuscular blocking drugs. This is the succinylcholine. The effective dose 95 of the succinylcholine is 0.27 milligram per kg intravenously, and routinely or very rarely we use the intramuscular dose in the doubling the intravenous dose. The dose of the regular intubating dose of succinylcholine is 0.5 to 1 milligram per kg. The onset is 30 to 60 seconds, and the duration of action lasts for 3 to 5 minutes in normal patients. The depolarizing blockade referred as a phase 1 blockade, as Dr. Rakhee Goyal said in the previous slides. A single large dose like more than 2 milligram per kg and also repeated doses as prolonged continuous infusion produces phase 2 blockade. It is known as the desensitization neuromuscular block. This is the slide showing how the succinylcholine affect in the neuromuscular junction. The succinylcholine binds to the 2 alpha subunits of the acetylcholine receptors, and the ion channel opens, causes the sodium get in and the potassium out. It causes the muscle relaxation, produces fasciculation, and the succinylcholine is not metabolized or hydrolyzed by the acetylcholine at the neuromuscular junction. so that sustained depolarization of the end plate occurs and the neuromuscular blockade will be happens. This is the diagram of the sodium channels. The sodium channels are the gated channels. In the resting state, you see the upper gate is closed and the lower gate is open. Once there is a depolarization, the upper gate opens, the sodium will get entered, but the lower gate is the time dependent. So it is immediately closes after the upper gate opens. So that is how the muscle relaxation will occur with the succinyl choline. The advantages of the succinyl choline is have the rapid onset, shorter duration of action. If a patient doesn't have any intravenous access, you still able to give the dose by the intramuscular, but the dose need to be doubled. And the disadvantages of the succinyl choline are it produces the hyperkalemia like 0.5 to 1 milliequivalents per deciliter, especially in the patients with previous burns, massive trauma, denervation injuries, and sepsis patient. There is a higher chances of increase in the potassium levels. And also it produces the cardiac arrhythmias, especially in the pediatric patients. So nowadays, a lot of pediatric cases, we are trying to avoid the succinyl choline with the possibility of any muscular dystrophies or any like neuromuscular disorders. And also it produces masseter spasm and malignant hyperthermia. Because of excessive like muscle fasciculation, there is a chances of postoperative myalgias in this patient. In the patient with the pseudocholinesterase, like atypical pseudocholinesterase deficiency or decreased levels, you may see the prolonged effect of the succinyl choline. Because of the fasciculation, there is a chances of increased intracranial pressure, intraocular pressure, and intragastric pressures. So patients with the raised ICP and the raised intraocular pressure, so it is very cautious to use the succinyl choline. So one of the major significant complications with the succinyl choline is the prolonged apnea because of mainly decreased or pathological variations in the plasma cholinesterase. The physiological variations of plasma cholinesterase is decreased in newborn patients and also in patients with the pregnancy. The pathological status where you see the decreased plasma cholinesterase like cirrhosis, it's seen the reduced up to 50% and also in the renal diseases. In patients with some of the malignancies like the bronchogenic carcinoma or gastrointestinal carcinoma, you may see the decrease of plasma cholinesterase and you may see the prolonged apnea. In patients with the burns, you may see decrease of plasma cholinesterase, and also in patients with the starvation and patient who took some metoclopramide also see decrease the pseudocholinesterase. The iatrogenic causes of decreased pseudocholinesterase seen in patients who received the medications like the ecthyopate, anticholinesterases, panchronium, phenolzine, plasmapheresis, glucocorticoids, organophosphates, and the cytotoxic drugs like the cyclophosphamide. On the other way, you may see the resistance to the succinyl choline in patients with the juvenile hyaline fibromatosis and myasthenia gravis. Dr. Abhijit is going to talk more about these conditions where you see the changes in the neuromuscular blocking drugs with the pathological states. The atypical cholinesterase deficiency only recognized after healthy patient experienced prolonged neuromuscular blockade like 1 to 3 hours after giving the succinyl choline. And the Dubocane number reflects the quality of the cholinesterase enzyme, like it is the ability to hydrolyze the succinyl choline and not the quantity of the enzyme. The atypical cholinesterase deficiency divided into 4 types. Those are the K variant, Dubocane resistance are the atypical variant, silent variant, and the fluoride resistant variant. The normal Dubocane number in the regular populations is 80, but in the atypical cholinesterase deficiency with the homozygous state, you may see the Dubocane number of 20 with a greatly prolonged effect of the succinyl choline. Coming to the non-depolarizing agents, the characteristics are you may not see the fasciculations with the non-depolarizing agents. These agents are very hydrophilic. The onset is slow, like it may take like 1 to 5 minutes for the muscle relaxation compared to the succinyl choline, it's prolonged. It is reversed by the neostigmine and other anticholinesterase medications. And in case of aminosteroid compounds, you can give the sugammadex to reverse the non-depolarizing agents. The effects are reduced by the epinephrine and acetylcholine. The relaxed muscle still responds to the other stimuli like the mechanical stimulus and also the electrical stimulus. In the partial paralysis, the neuromuscular monitor shows the fade, post-tetanic facilitation followed by the exhaustion, and the depression of the muscle twitch. The non-depolarizing agents are potentiated by the volatile agents and the hypocalcemia, hypermagnesemia, and hypokalemia. The mild cooling antagonizes the effects of the non-depolarizing agents, but the temperature of less than 33 degrees centigrade potentiates the effects of the non-depolarizing agents. And the repeated tetanic burst during the neuromuscular monitoring produces the wearing of the effect of the non-depolarizing agents. The acidosis increases the duration and the degree of non-depolarizing block. The classification based on the chemical structure of the non-depolarizing divided into benzyl isoquinoline compounds and aminosteroid compounds. The benzyl isoquinol compounds includes cisatracurium, atracurium, mivacurium, alcuronium, galamine, and oxycurium, and DTC. The most common agents in our practice, we use the atracurium and cisatracurium. The aminosteroid compounds like the rocuronium, vicuronium, and pancuronium. Coming to the atracurium, this is one of the non-depolarizing agents with aminosteroid compound chemical structure. It is a mixture of 10 isomers with the ED95 of 0.2 milligram per kg. The onset is 3 to 5 minutes and duration lasts for 20 to 35 minutes. 82% of atracurium bound to the plasma protein albumin. The iodide salt bisalate provides the water solubility and adjusts the pH 3.25 to 3.65 that minimize this spontaneous in vitro degradation. The one of the major thing with the muscle relaxants, because when you mix with any alkaline pH, there is a chances it may become the precipitate formation. So you have to be careful with the agents like the thiopentol. The potency of the atracurium when you store at the room temperature decreases approximately like 5% every 30 days. The atracurium undergoes a spontaneous non-enzymatic degradation like in 1/3, known as the Hoffman's elimination, and also it is hydrolyzed by the non-specific plasma esterases like the 2/3 metabolism. The major metabolite of the atracurium is the ladenosine. With the higher concentration, it may produce the CNS stimulation and causes the seizures. But the concentration need to produce the CNS stimulation is more than 16 microgram per ml. With a regular paralyzing dose of like 0.5 milligrams, you may produce like 0.3 microgram per ml of ladenosine. That means very, very minimal chances of CNS stimulation with these doses. So there is very, very higher therapeutic window for causing any CNS stimulation with the ladenosine in human beings. The Hoffman elimination is accelerated by the alkalosis and slowed by the acidosis. The ester hydrolysis in opposite direction of the Hoffman's elimination. It does not have the cumulative effect. One of the major side effects with atracurium is cause the histamine release and cause the tachycardia and hypotension. And the recovery is more rapid in the infants, like 23 hours compared to the adolescent patients. And there is no effect on changes in the effects in the elderly patients. The cisatracurium is one of the stereoisomer of the atracurium. The ED95 is 50 microgram per kg, and it is 4 times more potent than the atracurium. The onset, duration, everything is similar to the atracurium. But the production of ladanose is very minimal. Even with higher doses like 8 into ED95 does not produce any histamine release, so it produces the good cardiovascular stability. The other medication is the vicuronium bromide, is a monoquaternary aminosteroid. The ED95 is 50 microgram per kg body weight. The onset is 3 to 5 minutes and the duration of action 20 to 35 minutes. It is unstable in solution and routinely supplied as a lyophilized powder. And there is a minimal increased chances of lipid solubility, so it may be facilitated by the biliary secretion and also 40% excreted in the bile. 30% is excreted in unchanged in the urine, and elimination T off is prolonged with the patients with the renal failure because it have the active metabolite. The other effects are similar to the atracurium, but the only thing it still have the cumulative effects divide of the circulatory effects. The other medication is the rocuronium. It is the monoquaternary aminosteroid compound. The ED95 is 0.3 milligram per kg and structurally related to the vecuronium, and the potency is 1/6 of the vecuronium. But one of the major and good effect with the rocuronium, it have the faster onset with the higher doses. It act as similar to the succinylcholine with the 60 to 90 minutes of onset. But the duration is like atracurium, like 30 to 45 minutes with the minimal cardiovascular effects. This is the busy slide showing the comparative pharmacology of the non-depolarizing neuromuscular blocking drugs, what we talked. This slide showing the reversal agent. The most common reversal agent we used on practice, the neostigmine. It blocks the active site of the acetylcholinesterase, so the enzyme can no longer break down the acetylcholine molecules before they reach the postsynaptic membrane. The dose is 0.03 to 0.7 milligram per kg, injected intravenously over a period of 1 minute. Most of the time preceded by the anticholinergic agent. The maximum dose is 70 microgram per kg up to max dose of 5 milligrams. The side effects are mainly related to the muscarinic effects. It will be prevented by giving the anticholinergic agents like the glycopyrrolate or atropine. So the glycopyrrolate is the quaternary ammonia compound. It does not cross the blood-brain barrier. The other way, the atropine is a tertiary ammonia compound. It does crosses the blood-brain barrier and produces the central nervous system effects. The other side effects with these medications like the tachycardia and dryness of the mouth. Now, one of the major agent in like it advanced our neuromuscular blocking practice is the sugammadex. It's a modified gamma cyclodextrin with a lipophilic core and a hydrophilic periphery. It is indicated for the reversal of aminosteroid compounds like the rocuronium and the vecuronium. The mechanism of action is directly encapsulating, binding, and thus inactivating the rocuronium. It is like 95% affinity, and the vecuronium is 90% affinity. Later in 2019, they saw some hypersensitive reactions, and also there is interference with the medication like the oral contraceptive pills and the anticoagulants. So still some of the areas we need to worry about the sugammadex. And it is not recommended in the renal failure patients because the encapsulated molecules need to be excreted through the kidneys. So if the patient is in the dialysis, that may remove the compound. The dosages in emergency use with a no response, you may give up to 16 milligram per kg body weight. With the post-atonic count 1 or 2, you will give the dose of 4 milligram per kg body weight. And with the presence of a second pitch in the DBS, you may give the dose of 2 milligram per kg body weight. What happens if you need to give the neuromuscular blocking agents after the sugammadex? To reparalyze after the sugammadex, avoid any aminosteroid muscle relaxants for 24 hours preferably, because it causes a slower onset and also the shorter duration. But if you have to re-administer the rocuronium after the dose of 4 milligram per kg body weight, minimal wait time is 5 minutes, and the dose is like 1.2 milligram per kg body weight of rocuronium. With the minimum waiting time of 4 hours, you can give like 0.6 milligram per kg body weight. But as I said, the slower onset and the shorter duration of action will still occur. And it is still preferable to give the benzyl isoquinoline muscle relaxants. Nowadays, we are still advancing with the practice of the muscle relaxant. There are new muscle relaxants coming into the practice. They are still in the research practice. Those are the chlorofumarate diesters like the gantacurium, CW002 and CW011 and CW1759. These medications actually main intention is quicker onset, quicker offset, and easy reversal. Like gantacurium will be reversed with the L-cysteine. So this is still in the research practice. So we may see in the future with the holy grail of muscle relaxation effect. This is the busy slide showing the summary of the neuromuscular pharmacology. On the left side showing the depolarizing agents, on the right side showing the non-depolarizing agents divided into benzyl isoquinoline compounds, aminosteroids and the chlorofenerate diesters with the proper reversal agents. And so my conclusion is, as a perioperative physicians, we have to be the main judge for the patient care. So you need to understand the physiology, anatomy, and the pharmacology with your careful titration of anesthetic agents, and proper understandings of the patient pathophysiological changes plays an important role in determining the anesthetic outcome. Thank you so much for my opportunity.
Thank you, Dr. Lakshmi. Am I audible?
Yes.
Yeah, thank you. Good evening, everybody. And thank you, Dr. Lakshmi, for a very crisp presentation of such a vast topic. And even though Sugamadex is yet not available for us, but I'm sure it will be available soon in India. And thank you so much for sharing those tips on the use of Sugamadex. I know it's early morning out there, and probably your theaters are starting, but please stay back with us for the Q&A session. Thank you so much, Dr. Lakshmi. I now move on to our next speaker, and with proud privilege, I introduce to you Dr. Poornachand, NA, who is a consultant with us at Basanth Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. Poorna has keen interest in neuromuscular monitoring, and over the last couple of years, he's been trying the 3 different types of neuromuscular monitoring devices that we have in our department. And I'm sure Dr. Poornachand has got some very good useful tips for us while using these monitoring devices perioperatively.
Thank you all for giving me this opportunity. I proceed with my topic. So the topic for today is neuromuscular monitoring. So do we need to monitor neuromuscular blockade? The answer is yes. It helps us in monitoring the depth of neuromuscular block and to provide adequate relaxation for the surgical field, especially during laparoscopic and robotic surgeries, where we do not want jerky diaphragmatic movements. And the most important reason is to exclude clinically significant residual neuromuscular block after reversal administration, which otherwise is not possible with clinical methods. So what are the risks associated with residual neuromuscular blockade after extubation? There is decreased chemoreceptor sensitivity to hypoxia. There is functional impairment of the pharyngeal and upper esophageal muscles. So because of this, patient is not able to maintain an patent upper airway, which poses to risk of hypoxia, and the response to hypoxia is blunted. So also because pharyngeal muscles are weak, there is misdirected swallowing, causing risk of aspiration. For all these reasons, the perioperative respiratory complications are high when there is residual neuromuscular block. Therefore, Society of Australia and New Zealand and Great Britain and Ireland, they suggest objective monitoring of neuromuscular block be advised and should be part of standard perioperative monitoring, especially when we are using the muscle relaxants. So what are the clinical methods? I'll tell them in the next slide. Clinical methods to assess recovery from neuromuscular block. They're useful only towards the end of surgery, but are not reliable. Next is to stimulate a peripheral nerve and assess the response of the muscle. It could be subjective assessment, which is by visual or tactile means, or it could be an objective assessment with the help of a monitor. So these are some of the clinical methods that are being that we use commonly to assess patient recovery from neuromuscular block, like sustained head lift for 5 seconds, sustained leg lift for 5 seconds, sustained hand grip for 5 seconds, but all of these are unreliable and they cannot exclude with certainty residual neuromuscular block. So all these things, all these clinical tests, patients can pass at a top ratio of 0.4 and between 0.4 and 0.7. But for extubation, the criteria is 0.9 or more of top ratio. And while using a peripheral nerve stimulator, we need to know these things. Supramaximal stimulus, it is 15 to 20% more than that required for maximal response. We use supramaximal to overcome the resistance of the skin. Next, calibration of the device. Impedance is the resistance offered by the skin. New monitors display the impedance also. And there is something called safety margin. Neuromuscular transmission has a considerable margin of safety. That is, with the available stimulation patterns and the monitors, neuromuscular block becomes apparent only after 70 to 80% of the acetylcholine receptors are occupied with neuromuscular blocking drugs. And to produce a complete block, 90 to 95% receptors must be occupied. And we need stimulating electrodes. They could be surface electrodes. If the resistance of the skin is very high, then we use needle electrodes. So when we use needle electrodes, the current selected should be on the lower side, around 5 to 8 milliamperes. And the monitoring site should be easily accessible during the surgery, and it should allow quantitative monitoring. So the nerve muscle unit that is chosen should be topographically distinct. That is, to avoid a direct muscle stimulation when we stimulate a nerve. So coming to the, suppose we are monitoring a neuromuscular transmission, we should not compare results of one muscle group with another muscle group. And in fact, not the same, even the same muscle group on the contralateral arm also. The possible explanations are variations in the acetylcholine receptor density, amount of acetylcholine release, blood flow, innervation ratio, and muscle temperature. There could be differences of temperature on the, between the arms, so that would bring about variations in the response. So differential sensitivity of different muscle groups. Diaphragm and laryngeal adductors are the most resistant muscles to both depolarizing muscle relaxant and non-depolarizing muscle relaxant. Whereas the pharyngeal and upper esophageal muscles are the most sensitive muscles to non-depolarizing muscle relaxants. So that this is the reason, if you want to maintain a deeper level of neuromuscular block, diaphragm and laryngeal adductors have to be paralyzed. So the muscle that closely parallels these muscles is the corrugator supercilii of the eye. And as I said, pharyngeal and upper esophageal muscles are most sensitive. So for extubation, these muscles have to recover, like the pharyngeal and the upper esophageal. They recover very late, and this happens at a top ratio of 0.9 at the adductor pollicis muscle. So this is one of the gold standard site for neuromuscular monitoring, ulnar nerve and the adductor pollicis muscle. Because ulnar nerve is on the medial side and the adductor pollicis is on the radial side. This is another alternate site when the ulnar nerve is inaccessible. This is the flexor posterior tibial nerve, flexor hallucis brevis. So this is another monitoring site, facial nerve, and the response is assessed by measuring the muscle movement of corrugator supercilii. So here in front of the tragus, think of an imaginary line to the middle of the nose, negative electrode on the upper side of the line and a cathode on the lower side. So this is a temperature sensor, and this one picks up the muscle movement. It is a piezoelectric crystal wafer. So coming to the different nerve stimulation patterns, single twitch tetanic stimulation, train of force stimulation, double burst stimulation, and post-tetanic count stimulation. Most clinically useful stimulation patterns are the train of force stimulation and the post-tetanic count stimulation. This is a simple peripheral nerve stimulator that we use at our hospital. So coming to single twitch stimulation, it is a simple and simplest and earliest stimulation pattern, useful for calculation of supramaximal stimulus. Calibration is required for this stimulus, and a baseline value for reference is mandatory. And this is the only stimulation pattern with monitor to assess the depolarizing block after sectional pooling. TOF stimulation is the most frequently used nerve stimulation. Advantage with TOF stimulation is we can assess the neuromuscular block throughout the phase of surgery, like from induction till recovery. So subjective is through TOF, counting the TOF count, it is TOF count, and assessing the fade. And if you have a monitor, we can look at the TOF ratio. I have already told about these things. And one thing to remember is TOF ratio of 0.9 or more at adductor pollicis muscle is required for tracheal extubation. And fade with TOF stimulation, you can appreciate till a TOF ratio of 0.4. Beyond 0.4, fade is not appreciated visually or tactile. This is a small clip showing TOF stimulation. Here, four supramaximal stimuli are delivered at 2 Hz frequency. Visually, we can see all the 4 responses were equal. The monitor also displayed 99% on the monitor. This is an acceleromiograph mission. So next, double burst stimulation pattern was developed with an aim to detect the fade till a more higher levels, but it was possible only till a fade of 0.6. So still, but for extubation, we need a TOF ratio of 0.9. So this still cannot replace objective monitoring of neuromuscular blockade. A small clip on double burst stimulation. So here 2 bursts of stimuli are given. Each burst will have 3 impulses separated by 750 milliseconds. And visually we can see both the impulses were, both the responses were equal. Post-tetanic count. This is a painful stimulus. A tetanic stimulus is given followed by a single twitch stimuli. So this particular stimulus pattern is useful for assessing deeper levels of neuromuscular block. I'll show a small clip on PTC. So first, a tetanic stimulus is being delivered to the patient at 50 Hz stimuli. You can see sustained contraction of the muscle, followed by 3-second gap. Then we give single twitches at 1 Hz frequency. It depends on the mission. Between 10 and 20 stimuli are given. This particular mission delivered 10 stimuli and all the 10 responses were recorded. So the monitoring techniques include mechanomyography, electromyography, and acceleromiography. And there are some other techniques, but they are not used clinically or not available widely. Mechanomyography is the gold standard, but clinically not used because of bulky apparatus and not possible to set up in OT. It is not feasible. And coming to electromyography, it measures the action potential of the muscle on nerve stimulation, and the response is displayed on the monitor. So most widely used is the acceleromiography, and most widely available monitor is also the acceleromiography. So here we stimulate the nerve and the acceleration of the muscle movement is measured, and the value is displayed on the monitor. So this is an acceleromegraph monitor we have at our institute. It delivers all the stimulation patterns like TOF, tetany, double burst stimuli, post-tetanic count stimuli, and single twitches. This is a piezoelectric wafer applied to the thumb. This is another machine, another monitor we have at our institute. It is also based on acceleromegraphy. This has an additional temperature sensor. Temperature sensor to detect the temperature of the muscle. So in one of our monitors, we have a mode called ATP. It is called automated TOF PTC. So, for example, we need a deeper planes of block, neuromuscular block. We can use this mode. We usually use it. I usually use it for craniotomies. Though we give target controlled propofol infusions, and despite good analgesia with opiates, patients sometimes can have minor movements which would disturb the neurosurgeon. So I select this mode. It will start with delivering a TOF stimulation. Suppose if there was a response to the TOF, it will display the TOF result. Accordingly, we can take action by giving muscle relaxant and also ensure that good analgesia is given. Once TOF result is displayed, this mission again after a 30-second pause, it will enter the cycle. Let us think there was no response to the TOF. Then it will deliver a PTC stimulation, and the response is displayed. For deeper levels of block, the PTC count has to be maintained between 1 and 3. Once a PTC stimulus has been delivered, the machine goes into a 5 to 6 minute pause and again enters the cycle. So after tetanic stimuli, there should be a 6-minute gap before we stimulate again. And for TOF, it has to be 10 to 12 seconds gap before we repeat it next stimuli. So various stimulation patterns. First is single twitch, useful for finding supramaximal stimulation and time to tracheal intubation. TOF will help us in guiding tracheal intubation timing, and TOF cannot quantify deeper levels of block. Intense and deep blocks cannot be quantified by TOF. So at a moderate block, TOF is useful, and towards the reversal, it helps us in guiding when to give reversal, at what dose of reversal should be given. Also, TOF ratio will give an idea. Whereas PTC count, it will give us a depth of block at deeper levels, intense and deep blocks. Double burst stimuli was developed to with an aim to improve in detecting fade, but it was possible only till a TOF ratio of 0.6, which is still insufficient to rule out clinically significant neuromuscular blockade. Dr. Lakshmi Narasimhulu sir has already spoke about these things. I'll just brief it. So when we do a quantitative neuromuscular monitoring, Sugammadex can reverse any level of block. So if there is no TOF count, no PTC, that is intense block, 16 milligram per kg of Sugammadex. If there was a TOF, no TOF and PTC count there present, Sugammadex 4 mg per kg. If TOF count was there between 1 and 4, then Sugammadex 2 mg per kg, and if TOF ratio is more than 0.9, no need for reversal. Similarly, for neostigmine, if TOF count is 0 to 1, delay reversal till a TOF count of at least 2. With a TOF count of 2 to 4, with a TOF ratio less than 0.4, neostigmine dose advised is 50 microgram per kg, but still it is advisable to wait till the appearance of fourth twitch. TOF ratio between 0.4 and 0.9, neostigmine dosing would be 20 microgram per kg. And if the TOF ratio is more than 0.9 or equal to 0.9, no need to give reversal. In fact, it would cause a paradoxical neuromuscular, it would cause a paradoxical block of the junction. This is also a similar slide. I think I'm done with this. Thank you all.
Thank you, Dr. Poornachand, so much for sharing a lot of practical information and tips on using various neuromuscular monitoring techniques and modes. And I think most importantly, emphasizing the importance of using a neuromuscular monitor whenever you are using neuromuscular blockers. I'm sure there are going to be a lot of questions for you. So please stay back for the Q&A.
Yeah, sure.
We move on to our next talk, and our next speaker is Dr. Abhijit Nair, and with a lot of with happiness, I introduce Dr. Abhijit Nair, and he is currently working as a consultant with the in Muscat, Oman, and Dr. Abhijit is passionate about regional anesthesia. He's done his Indian diploma in regional anesthesia. He is also a fellow with NIV, and he's an avid reader and a prolific writer. At such a young age, he has more than 100 publications, PubMed indexed, and he was last year awarded as the best reviewer by Indian Journal of Anesthesia. So having worked with Dr. Abhijit, I know that he's a very passionate perioperative physician, and we've requested him to talk on anesthetic implications in patients with neuromuscular disorders. So over to you, Dr. Abhijit. Can you please share your screen?
Yeah.
Yeah.
Respected teachers and dear colleagues, thank you, Eva Madam, for the kind invitation. I have nothing to disclose. The topic that I have been asked to speak about is neuromuscular disorders, its anesthetic implications. I always prefer to start with a little historical aspect, if at all there is any. So regarding neuromuscular disease, it was first described by doctors Conte and Gioja in 1836. It was about two brothers who had some unknown, undiagnosed progressive neuromuscular disease. They have published their work also, but somehow they didn't get any much popularity. However, in 1864, Dr. Meron published his reports of 11 patients with certain neuromuscular disease, which he analyzed and wrote in great depth. But it was in 1868, which was when Dr. Guillaume Armand Duchenne de Boulogne, yes, you are right, you got it right. This is the gentleman who described Duchenne's muscular dystrophy. After that, this particular entity started gaining importance, and there was a lot of research done and a lot of new diseases identified. 1876 by Thompson, myotonia congenita, and in 1909 was myotonic dystrophy. So neuromuscular disease is a complex challenge to the perioperative physician due to its susceptibility to NMJ and muscle function, to a lot of anesthetic medications. It can be hereditary or acquired. These patients can have progressive multi-system involvement. The most important concern in these patients for anesthetizing them is post-operative respiratory failure. I'll just brief about the hereditary and the acquired diseases. Hereditary, we have pre-junctional, which is Charcot-Marie-Tooth disease and Friedreich's ataxia. Post-junctional, they are dystrophies and myotonias. Most common is Duchenne's muscular dystrophy and Becker's muscular dystrophy, and a few more myotonic diseases. Among the acquired neuromuscular diseases, it is divided into pre-junctional and others. Pre-junctional are motor neuron disease, multiple sclerosis, Vaibhavari syndrome, and diabetic neuropathy. In others comes myasthenia gravis, Eaton-Lambert, critical illness, polyneuropathy, and critical illness myopathy. So coming to preoperative management, what we need is if any patient with underlying some kind of muscular dystrophy, we need to have a precise diagnosis. We should ask for the previous details, previous hospitalization, previous surgeries, previous complications, if any. The disease status has to be known in the form of either a marker or CK or creatine kinase level. They should be investigated, I mean, rather examined from neurological point of view, milestones, their cognitive function, and even for a small surgery, even for a diagnostic procedure, also the patient, if is in proper cognition, or the family should be counseled about the possible risk and complications. And if they are for any major surgery, then of course the planning has to be a meticulous planning, and the meticulous preoperative preparation is mandatory. The relevant investigations for these patients, I mean, including the regular hematology work, urea electrolytes and creatine kinase, ECG, chest X-ray, echocardiogram, pulmonary function test, and baseline arterial blood gases. These are the tests which are required. It can be individualized on a case-to-case basis depending on the patient's condition. As you can see over this slide, this slide gives you an idea of what special preoperative workup needs to be done in particular disease. For example, an echo for Duchenne's and Becker's, for myasthenics a PFT, for Lamont-Eaton PFT, again for Guillain-Barré also PFT if possible. What is another important thing to know is what are the drugs which could amplify neuromuscular blockade in presence of neuromuscular diseases. They are corticosteroids, aminoglycosides, vancomycin, quinidines, ester-type local anesthetics, furosemide, calcium channel blockers, and even beta blockers. Monitoring intraoperatively should be meticulous. Of course, the regular ECG, oxygen saturation, capnography, and arterial line, if mandatory, if necessary. But as Dr. Poorna mentioned in his presentation, a quantitative neuromuscular monitoring is mandatory if at all you are using neuromuscular blocking drugs in these particular patients. Now, thermoregulation, it is of course it is a standard of care for any patient undergoing any kind of surgery, but these are the patients, for them it could be a double-edged sword basically. The idea of this patient, of course, for all patients it has to be euthermia, but these patients are vulnerable to hypo and hyperthermia as well. Hypothermia could exacerbate myotonic diseases. It could increase the sensitivity to muscle relaxants. It could aggravate rhabdomyolysis. It could lead to coagulopathy and arrhythmias. Of course, hyperthermia, we all know when we talk about hyperthermia in neuromuscular disease, malignant hyperthermia comes into mind, which is like evident in the form of increased CO2 and tachycardia and a temperature at times more than 40 degrees centigrade. Regional anesthesia has a lot of potential advantages over general anesthesia for obvious reasons, but the problems are these patients could have, because if the disease is for quite some time, for a decade or two, they could have spinal deformities. They cannot position for any regional anesthetic technique for central neuroaxial block, and they might not be very cooperative. So there are times when over enthusiastic regional anesthesia could be counterproductive, because these patients could have underlying cardiomyopathy. They are very much prone to arrhythmia. So that is the reason why a detailed evaluation is necessary. But there is a grade 1C recommendation that wherever possible, regional anesthesia should be used except in multiple sclerosis. So now this is a slide which shows like it can be used basically for every particular disease wherever possible. Coming to general anesthetic, when regional anesthesia is not possible and you have a patient, this kind of patient for surgery, the key is this should not be forgotten: trigger-free anesthesia and clean machine. Trigger-free means drugs, agent that can trigger any kind of issue, any kind of crisis. For example, succinylcholine, halogenated volatile anesthetics, anticholinestrases, and a clean machine is a machine which has from which volatile anesthetics has been totally flushed out. So this is the meaning of a clean machine. The problems, another problems of volatile anesthetic, other than causing malignant hyperthermia, it could cause cardiovascular depression, arrhythmias, and such kind of hemodynamic problems. Therefore, total intravenous anesthesia using propofol, dexmedetomidine or opioid, short-acting opioids is advisable in such patients. But then even TIVA has to be meticulously monitored because cardiovascular compromise could be imminent in certain kind of patients. There are hell of a concern with use of neuromuscular block in these patients. Depolarizing agents is a strict no, because succinylcholine, you must have got an idea from the first two presentations. Succinylcholine causes hyperkalemia, rhabdomyolysis, and muscle fiber swelling. In myotonics, it could actually temporarily cause temporomandibular muscle spasm, and which could actually prevent magma's ventilation and intubation. In fact, you might actually lose a patient. Surprisingly, in myasthenia gravis, there is a resistance to the dose of succinylcholine. More than twice the dose can be used, but then this is also a double-edged sword. It can cause phase 2 block. Let me make a point over here. I mean, I had worked at Pasvatarakam, and I mean, we don't use as a rule succinylcholine. I don't remember using it over there. I mean, knowing the problems and all, and there are better drugs to use. So that is one more point that I wanted to make. Non-depolarizing muscle relaxant, it causes respiratory weakness, atelectasis, inability to wean from ventilation, sputum retention, and dysphagia. This is because the effect is more profound. The recommended dose is 10 to 20% of the estimated dose for a particular patient, and the drugs that should be used is a short-acting drug like mivacurium, if available, or else intermediate-acting drugs like atracurium and atracurium. The advantage is because they have Hoffman's elimination, so you can ventilate the patient and then extubate comfortably when they fulfill the essential extubation criteria. Anticholinesterase are not recommended in muscular dystrophy because, like succinylcholine, even they can cause hyperkalemia and hyperkalemic cardiac arrest. Analgesia is very important. What happens is in such patients, we are so obsessed in neuromuscular monitoring and other things that sometimes it should not happen that we lose the attention towards pain control. Titrated short-acting opioids, postoperatively patient control analgesia, regional anesthesia techniques, central neuroaxial, peripheral nerve blocks. It can be judiciously used wherever indicated, wherever possible. Let me make one more point over here. These patients are not suitable for daycare surgery. However stable or however investigations look normal or the patient looks healthy, it is advisable because these patients are very unpredictable. So better to keep them in an ICU or at least a high dependency unit and initiate physiotherapy, spirometry, non-invasive ventilation if necessary. The best could be these patients could have some cognitive dysfunction. A high flow nasal oxygenation can be very comfortably used in such patients. Keep them pain-free and write clear post-operative orders for these patients. Now coming to respiratory failure, the causes are basically they have, because of the nature of the disease, it's a neuromuscular dystrophy. So respiratory muscles as such are weak. They have bulbar dysfunction. They can't cough out well. The secretion management is a problem as such. Post-operatively, again, it is even more problem. They have underlying cardiomyopathies. Over a period of time, they develop restrictive lung disease. All this put together, any one point or all points put together, they cause a lot of respiratory issues in the post-operative. Now the complications, these are like rhabdomyolysis, metabolic acidosis, hyperkalemia, myoglobinuria, pyrexia. These are all drug-induced. But arrhythmia per se, because of the vasodilatation or underlying cardiomyopathy with any drug, even with TIVA, regular TIVA, it can happen. The hypotension could be refractory. Of course, as I mentioned in the previous slide, it is very difficult to wean and extubate such patients, and risk of aspiration is always there. Autonomic dysfunction is one of the characteristic of these neuromuscular diseases, including, as we all know, it is also part of diabetes mellitus. So that is the reason why whenever necessary, invasive monitoring an arterial line and the central line, if necessary, depending on the type of surgery, should be used for vasoactive drugs. Gastric dysmotility due to autonomic dysfunction leads to regurgitation, aspiration, etc. And the sympathomimetic drugs should be reduced because of the increased sensitivity of the receptors. Now, myotonic contractures are another problem which is seen in dystrophic and non-dystrophic myotonias. This is because of repeated action potential leading to permanent sodium influx or chloride efflux across the muscle membrane, which makes it quite hyperexcitable. So in that case, whenever a myotonic contracture is triggered, it is not responsive to neuromuscular blockade or local anesthetic or whatsoever. The best thing in such situation is to remove the factor which precipitate, which is most of the times succinylcholine, anticholinesterase, or certain opioids. This I have mentioned already in the in one of the slides previously, but I would like to emphasize bulbar muscle weakness is a problem. They have poor pharyngeal and respiratory resting tone. They have spinal deformities and restrictive lung defect, and have a extremely difficult post-operative course, especially after extubation. So this is a slide showing all the neuromuscular disorders and the associated cardiovascular effect. Most of them, they have dysautonomia, and some of them have arrhythmias and conduction defect over a period of time, and the certain disorders, they have underlying cardiovascular. Now, MH, we always keep hearing about MH. Now and then some case report comes, or we read in some of the communications. I have not experienced yet, and I don't want to per se, because whatever I have heard is very scary. But then everybody should have an idea about this, because these patients are patients with neuromuscular disorders are at increased risk of developing MH during anesthesia. It could be because of use of succinylcholine, use of volatile anesthetic. A high index of suspicion is necessary, and it needs an extremely aggressive management. First thing is to discontinue the trigger, deliver 100% oxygen. Dantrolene is something which, I mean, it is subject to availability. It is not available in many places. In fact, if you have a patient and you expect a problem, it is better to indent it and keep it, because at the last moment, getting dantrolene is a big problem. I have experienced it. I mean, few of my friends, I have heard through them, they had a problem. Unfortunately, nothing happened. So the dose is 2.5 milligrams per kg bolus and 1 milligram per kg till symptoms resolve, signs and symptoms resolve, and then 1 milligram per kg every 6 hours for 48 hours under close monitoring. Bicarbonate infusion, sodium bicarbonate is essential in presence of metabolic acidosis. Aggressive temperature management, correction of hyperkalemia, and in case of any imminent cardiac arrest, follow the principles of advanced cardiovascular life support. Now I would come to individual diseases. I won't discuss all the 25-30 diseases, just a few of them which are most common. The most common is Duchenne's muscular dystrophy, which is 1 in 3,500 live birth. They develop waddling gait between the age of 3 to 5. By the age of teenage, they are wheelchair bound, develop contractures, scoliosis, cardiomyopathy, and they usually don't survive after second to third decade of life. They usually come for many diagnostic procedures or a lot of contracture release and all these things. The Becker's muscular dystrophy comes in the next, comes a close second, distant second actually, 1 in 30,000 births. It is a little milder than Duchenne's. The symptoms start with teenage and they live up to 4th or 5th decade of life. But again, the reason is respiratory failure or cardiac arrest due to underlying cardiomyopathy. As we all know, these are the cases which are very rare and there are no randomized study. It is impossible and it's unethical. But then what we have is a lot of case reports and case series. This is an interesting review of 117 anesthetic procedure in 47 patients. Total of Duchenne's and Becker's, where they have concluded that use of succinylcholine is contraindicated. Probably, I mean, they have seen several patients undergoing, developing rhabdomyolysis and hyperkalemic cardiac arrest. So their conclusion was, it is not even, it is barely less than a decade back paper. So this is the conclusion of this paper. So coming to anesthesia consideration, depolarizing agent except for myasthenia gravis, it should be avoided. It should be avoided for Duchenne's and Becker's. 10 to 20% of non-depolarizing muscle relaxant with monitoring can be used, but then extubation has to be planned carefully. PIVA to be titrated carefully and a clean machine. Now coming to myasthenia gravis, this also we get these patients mostly for thymectomy. They have IgG autoantibodies against acetylcholine receptors within the neuromuscular junction. They are mostly on cholinesterase inhibitors, preoperative plasma exchange, immunosuppressants, and anti-immunoglobulin. One thing that we have to remember is the preoperative plasmapheresis could be helpful in having a better control of the disease, but then certain drugs can have prolonged action after an immediate plasmapheresis. So this Osserman disease severity is used to grade the severity of myasthenic, basically per se to guide us whether the patient will need a postoperative ventilation. Any grade above 2 is considered severe, and they should be managed, they should be ventilated postoperatively in the ICU. So the perioperative management, 10% of normal dose of non-depolarizers. Depolarizing blocks, although it is indicated and they need a higher dose, I mean not indicated, can be used, but then they are susceptible to phase 2 block. Cholinesterase inhibitors should be avoided because it prolongs the duration of neuromuscular blocking agent. All the list that I showed you regarding the drugs that interfere with transmission should be avoided, and ventilation is usually necessary. Coming to motor neuron disease, there are many primary lateral sclerosis, progressive spinal atrophy, and amyotrophic lateral sclerosis. In this disease, that doesn't affect the cranial nerves. They have fasciculation weakness and atrophy. So this is also one not very common, but you should know because this is something which is discussed very frequently. Again, here we have to avoid depolarizers and non-depolarizers. 10 to 20% of the dose we can use. These patients also pose serious weaning difficulties in the postoperative. Now coming to Vaibhavari syndrome, it is an ascending weakness, compromises the respiratory system, prolonged ventilatory support is required in the when they develop the syndrome basically, and they could have bulbar dysfunction. So again, the principles remain same here, but here regional anesthesia, if possible, can be safely used. But again, these patients need meticulous monitoring. Eaton-Lambert syndrome, as we all know, it is associated with lung malignancy, with ectopic production of antibodies against calcium channels. In contrast to myasthenics, these patients usually the weakness improves with exercise, and the cranial nerve involvement here is relatively less. Here, in this, they have increased sensitivity to both depolarizing and non-depolarizing insulin vaccine. But however, you can use anticholinesterase in these patients. They have a potential for autonomic dysfunction because of lack of acetylcholine. And again, in such patients also, ventilation is usually eminent. Now coming to Sugamadex, Dr. Lakshmi had mentioned about the use of Sugamadex, but this is an interesting systematic review of case reports published very recently where they have mentioned because the response of Sugamadex in such patient, it is very unpredictable. The reason is the dose starts from 2 milligrams and it is up to 16 milligrams. We don't know the dose. The type of agents that were used in these patients in this case reports, in this review, basically they were all different. It was all mixed. So that is the reason why with this review, they mentioned that Sugamadex, although it is better than other anticholinesterases, but the response is unpredictable and still it is not very, very safe. As I mentioned, there are no RCTs with this entity, but these are two very interesting review articles. One was published in Canadian Journal of Anesthesia this year itself. The article is very interesting and it's a scoping review which mapped the current evidence of anesthetic management of adult patients with neuromuscular disorders. And the second one is in 2013. It came in Minerva Anesthesiologica. Again, they have come out with very nice recommendation based on grade system. So to conclude, a thorough preoperative evaluation is necessary. Avoid suxamethonium as far as possible. Quantitative neuromuscular monitoring is a must. Do not hesitate to revise or read prior to dealing with such cases. We don't deal with these cases. I mean, we might be dealing with a severe LV dysfunction more frequently, or a septic patient for anesthesia more frequently, but these are not the patient who comes now and then with us. So it is better. You should go through the textbook again, go through literature again, and then start your planning. And Sugamadex possibly safe in neuromuscular disease, but having said that, it's not available in India right now. So these are my references. Thank you very much for the opportunity.
Thank you, Dr. Abhijit. Thank you so much. I know it was a very, very vast topic, and you covered it really well, partly with the speed of your speaking, because you really went quite fast through all of that. You gave a very good overview about how to overall deal with patients with neuromuscular disorders, and you touched upon important ones. As you rightly said, that malignant hyperthermia is not very common in our country as compared to that in the West. But when it happens, you should just be ready, prepared to handle it and manage it. With this, I open the session for Q&A, and I request all the panelists to keep their videos open. I'm going to start with Dr. Basanth. Are you there? So actually, the topic of this webinar has been a brainchild of Dr. Basanth, and my first question is going to be for him, that why did you want to select this topic?
Right. As anesthesiologists, we are always the patient's advocate, and safety is at the center of everything that we do. And I've realized over the years, the recommendations for neuromuscular monitoring, neuromuscular reversal have actually got, they've changed completely. And yeah, they've become more stringent. And yeah, though it's helpful in improving patient safety, neuromuscular monitoring is one area which is infrequently used. There could be various reasons: non-availability of the equipment, lack of knowledge, or just being uncomfortable with using the equipment. So there are various reasons for that. Though we know that it could improve the safety of the anesthetic and the safety of our practice. So that is one reason I thought we should take up this topic. And if we could bring up change in practice in at least a few people and a few centers, this webinar has achieved its what it was supposed to go. Yeah,
that's right.
Yeah,
I'm so glad you brought this up, Basanth, because this is basically the crux of this whole session, that we are the single largest users of muscle relaxant in as physicians. Nobody else paralyzes a patient and then takes over their ventilation, except maybe in an ICU setting. And how do we really know? I mean, this is so important. About when Dr. Lakshmi and Dr. Rakhee and Dr. Abhijit and Dr. Poornachand stressed, the importance of knowing where our drugs act, what happens, what are the factors that cause problems. And this is what has always been on my mind. And maybe we'll come to that question later on. What else can we do to emphasize either to our trainees or to our fellow anesthesiologists the importance of knowing about the rational use of neuromuscular blocking drugs. So that's what I would really like to ask Dr. Lakshmi. What would you advise as a rational use of neuromuscular blocking drugs in one's clinical practice? So I'll tell you why I'm asking you this. Is because I know, I'm not sure about you, but I have seen very often that, say, you have either a laparoscopic procedure or a robotic, or you have a laparotomy, and or even an orthopedic procedure, and the surgeon says, "Are you sure the patient is relaxed, or the patient is bucking? Do something." And then you say, "Oh, I've just given it," and then the next time you give saline, say, "Oh no, this fellow, I can't give him enough relaxant, so let's bluff our way around." But the point is, so what would you advise as rational use?
It happened to me, Dr. Elsa, many times. The surgeon actually told me, you need to give 20 milligrams of racloronam. I give 2 cc of saline because I don't have any twitches for this patient. And the surgeon, "Oh, very good, excellent, everything happened." So our rationale for using the muscle relaxant, we cannot able to have a fixed rules here. We have to go case by case basis. So, and the availability of the medication and available the neuromonitoring. like neuromuscular monitoring. So it can be the cost, it can be the onset of medication, duration of the medication, the patient factors like any systematic diseases. And those are the main factors we need to see. And every case is like some patients, like for example, I did a myasthenic patient last month. Our practice is, okay, this patient is resistant to the depolarizing agent and very sensitive to the non-depolarizing agent. But I spoke with the surgeon, I spoke with my providers. We plan to go with like a regular induction intubation without the muscle relaxant, using some lidocaine, LTA and all. And explain to the surgeon, we'll try to keep every possible way to keep well relaxed throughout the procedure. It is a robotic bariatric surgery. The patient did okay, did not give the muscle relaxant. So as a team, we need to approach for every case and talk with each other, make sure the patient will benefit from that one. The advances is very like the advances of the medication, the advances of neuromonitoring will be there, but as anesthesiologist, you are the one make a better outcome for every patient. We are the base, but nobody will see the base. Most of the times the tip is the one people will see, but we are fine. I'm okay with that.
No, I think one has to be a little more, what can I say, proactive. And once they know that you are talking sense, then they listen to you and you get your due respect. I just have, there was a question about about succinylcholine from Dr. Basanth, or intramuscular succinylcholine in clinical practice.
So the intramuscular succinylcholine, we use routinely in the practice of where the patient doesn't have the IV, like in a pediatric patient losing the IV with a laryngeal spasm. So that way we can able to avoid the complications of the laryngeal spasm. The dosage is like the double the dose of intravenous use. But in a regular practice, we'll try to avoid any intramuscular uses because onset sometimes unpredictable and the duration is also unpredictable compared to the intravenous. So far the only like a recommendation for the use of intramuscular uses of the succinylcholine, where the pediatric patients or even the adult patient to reduce break the laryngeal spasm related and prevent any negative pressure pulmonary edema.
Yeah, thank you. With the mention of pediatric patients, I'm going to move on to Dr. Rakhee. We know who's a pediatric anesthesiologist. So Dr. Rakhee, what are your concerns using neuromuscular blockers, particularly in neonates? And can neuromuscular monitoring be used effectively in them?
Thank you, Viva. So when it comes to neonates, it could be a term neonate, it could be a preterm neonate. So the whole scenario is different. As I mentioned, there could be some extrajunctional receptors, the fetal receptors of nicotine acetylcholine fetal receptors. So with that, they are very sensitive to depolarizing agents, and maybe the block of non-depolarizers could extend. They might be resistant to the dose, but then the block may be prolonged. So there are two things. One is the receptors, and they behave differently. Second is their metabolism. So when we give a non-depolarizer, they need to be metabolized. And in neonates, and especially the younger ones and prematures, that metabolism is going to be slow, as we know with all the drugs. So whatever drug you give in whatever dose is going to stay longer. So that's why most people, when in conventional practice, they do not want to give too much of relaxants to a newborn. Well, if you titrate and give, you should. Earlier, I believe awake intubations were common, and now we all give relaxants to intubate our neonates. But yes, we are very, very cautious. Now coming to monitoring. Now, I did check the literature. Of course, I don't do neonatal neuromuscular monitoring, I must admit. But even the literature is very limited. There is practically nothing. There was a survey in 2014 in 54 different institutes in the UK. and they didn't find people doing neuromuscular monitoring in neonates. So I really don't know, maybe, Dr. Lakshmi or Dr. Abhijit, or rather Dr. Poorna, who's into neuromuscular monitoring, would tell us about neonatal neuromuscular monitoring, because I haven't heard or seen or read about it.
Yeah, Dr. Poorna, actually, we do not do neonates at Basanth, so I'm sure he does not know about the neonatal. Is there anything in the literature that you want to add, Dr. Poorna?
Regarding neonates, I'm not sure, madam. But in general, I think, well, Elsa madam has asked whether do you recommend neuromuscular monitoring on a routine basis. I would say yes, if we have technology, rather than keep it aside unused. That happens in our institute also. Not many use it. Many use it, and it's again at personal discretion. But I think if it is available, we have to use it. Reason being, the most sensitive muscles are the pharyngeal and upper esophageal muscles.
Exactly.
So recovery in these muscles happen last. And the patient can perform a head lift for 5 seconds, sustained hand grip for 5 seconds. All these are possible at a TOF ratio of 0.4 and 0.7 also, between 0.4 and 0.7. But in majority of the patients, the pharyngeal muscles and upper esophageal muscles recover at a TOF ratio of 0.9, which is missed on a clinical basis. These patients tend to have upper airway collapse and hypoxemic events. That is a reason a patient breathing well on tube, opening eyes, he protrudes tongue, he follows your commands, we take out the tube, and we see that he struggles to breathe, and sometimes re-intubations do happen. This is the reason, because the most sensitive muscles are the pharyngeal and upper esophageal muscles. And ma'am.
No, go ahead.
So recovery at TOF recovery at the adductor polysis is considered standard site of monitoring to assess the recovery, because once the adductor polysis has recovered to a TOF ratio of 0.9 or more, that means we are sure that the upper pharyngeal muscles and esophageal muscles are also required to a good extent.
Yeah, I know that's a very relevant point that you've brought up, because I mean, I don't know. I remember at one time we had a lot of, we used to see a lot of patients having respiratory depression post-operatively, especially when you have this very cold operating room. And as you said, a patient who has a foreign body in their throat or in their larynx is bound to cough. And so a lot of inexperienced anesthesiologists, or if you're in a hurry to do your list, you extubate, and then you hand over into the, or you don't even know if you hand over in a post-op care unit that's very busy, and may not even have adequate monitoring. You might have 6 monitors and 20 patients there. So, these are all the practical problems we face in our setting in India. I had another question for, so the whole thing is, when you look at the drugs, neuromuscular blocking drugs, there are 2 aspects that have been highlighted in terms of safety. Why Dr. Basanth was talking is about, one is awareness. The awareness in anesthesia is much higher in patients where you've used muscle relaxants. And the second one, of course, is the respiratory problems that occur. And I think this is the whole thing, that you give the relaxant and thinking the patient's not moving, and therefore you cut down on your anesthetic agent so that you can wake the patient fast and your turnover time is faster. I think we're using this double-edged sword and nipping our own tails. I just have a little comment about neuromuscular blocking. I mean, in 1986, I was working in London, and there was this young anesthesiologist who was also interested in biomechanics, and he made his own neuromuscular monitoring device. It had 2 little prongs on it, and you put a little jelly and put it over the ulnar nerve. And I got so excited I didn't have much money, but I spent 50 pounds and I bought it and I had it in my pocket right at that time, from 1987. And I started using it on every case. And that's when I realized that how often my clinical judgment wasn't really right, that I might have actually not had the adequate train of 4. And I thought the patient was doing okay. So I found it so exciting that I used it. Dr. Hand over to you, Dr. Vibha. Any other questions?
Yeah, I think we are nearing to the closing time. Is it okay if I ask one question to Dr. Abhijit? Jayashree ma'am, can we
Sure.
take one last question before we hand it over?
Of course, you can.
So, Dr. Abhijit, we actually wanted you to tell us about children with cerebral palsy and osteogenesis imperfecta. What would be your recommendations perioperatively for using neuromuscular blockers in them? You're muted. You're muted.
It has been observed for certain reasons. I mean, that in patients with cerebral palsy, they require a more than higher dose of non-depolarizing muscle relaxant. I mean, although it is not very clearly elucidated the reason, but one of the factors is probably they are on anticonvulsants, phenytoin sodium or some other kind of thing. So because of this, probably they need a little more than higher dose of non-depolarizing muscle relaxant theoretically. Regarding osteogenesis imperfecta, I mean, I am sorry, I haven't encountered a case yet. So maybe I think you or Elsa madam can highlight about this.
Yeah, probably there aren't any specific contraindications for.
Yes, of course, that's what I understand. Yeah. But
I mean, there were a couple of cases, but no. Nothing unusual.
No, the reason I asked that question is actually, there is supposed to be certain incidents of malignant hyperpyrexia in this group. They get the tachycardia, but due to other reasons. And so therefore, some people are fearful of giving muscle relaxants, but we have a very large series in Manipal, where probably the largest. So, theoretically, you have the possibility of malignant hyperpyrexia. I have one more question for Dr. Abhijit. When you said a clean machine, so do you recommend, I mean, you need to have your monitors on, and you need to make sure that the expired air coming out from the machine has no inhalational agent, or how would you know if there's no inhalational
madam,
agent?
In certain text, they have mentioned it like that, like connect test lung, and then accordingly you start ventilation and flush it out. But in most of the places, what they do is they keep the gases on and they remove the vaporizers from the stream, and they flush it for some, I mean, really undefined time. So whatever said and done, a machine, to keep it trigger free is very difficult. But one thing that can be done is, in such cases, if you use an ICU ventilator, probably that will be totally prevent any kind of catastrophes.
Yeah, and probably also have to change the soda lime.
Yeah, of course. Changing, I mean, soda lime has to be changed, the circuits has to be removed, and you have to keep the flows on. And actually, I mean, theoretically only it will clear, but still, I mean, you never know, because the trigger can be a very small trigger also in certain patients. So I mean,
the transfer ventilators that we use could be a good option.
Yeah, even any ICU ventilator actually has a lot of role in intraoperative use, basically because of the type of ventilation it can offer. So this is possibly one of the indications.
And we use the charcoal filter also, along with the flushing for 10 to 30 minutes, removing the vaporizers, changing the canister. And we use the charcoal filter, so that actually helps to remove any remain gases.
Okay, that's useful to know. Yeah. Well, I think we have to come to the end of this session, and I can't thank all of you enough for the excellent presentations, which I thoroughly enjoyed, and for the revered presence of Dr. Radhakrishnan. It was very excited to see. And I thank all the speakers and Dr. Basanth and Dr. Vibha for making this possible, and to Kleinet. And I hand over to Dr. Jayashree. Thank you.
Good evening, everybody. What a pleasure to have had this webinar, and it was so excellent, and I'm sure the students really benefited, so did we. And the extra things to add was that I was so happy to see Elsa moderating the session. Thanks, Elsa. So nice to see you after such a long time. And Vaibhavari and and Dr. Basanth. That was very nicely moderated. And of course, the lectures were so clear and crisp and clear that I'm sure all the students have benefited. Dr. Rakhee, Dr. Lakshmi, Dr. Poornachand, and Dr. Abhijit. I mean, there are no words to express my thanks. Everything was so crystal clear. So thank you very much. And we hope to see you again sometime moderating and speaking on the ICA webinars. Thanks a lot and see you all next week. Thank you.
Thank
Thanks
you.
a lot.
Thank you,
It was
everybody.
great. Thank
Yeah.
you so much.
Thank you.
Yeah.
Thank you all. Good night.
Such a pleasure listening to all of you.
Yes,
Really.
yes, it was. Yes,
Yeah.
it was. Thank you
Take
so
care.
much.
Thank you very much.
Yes, you too. All of you. Thank you.
Good night.
So next week, what
And
are
good
we
morning, Dr. Lakshmi.
And next week, if you can tell us what is our webinar, that's next week. Yes, so it's on opioids, which is of course the in thing these days and the talk of the country in USA. And the topic is current and evolving concepts of the opioids on the 25th May. So we look forward to meeting all the students and the delegates and the attendees. Thank you very much. Good night.
Good night. Thank
Dr.
you.
Radhakrishnan, Dr. Sanish, thank you very much.